We have the Deputy Executive Director, Diana Kete from UNFPA, the Assistant Secretary General, and we will start our program now. Please. Yes, I will. Just give me a minute. Once again, good afternoon, everyone, and welcome to this side event on Achieving Sustainable Development Goal Target 3.1 through South-South Learning, organized by the Government of Nepal and UNFPA. My name is Bandana Rana, and I'm a rights activist from Nepal and also a member of the UN CEDAW Committee, and I will be moderating this event. Over the 3 decades since the adoption of the ICPD Program of Action, the South Asian region has achieved remarkable progress in various facets of sexual and reproductive health and rights. Although the MMR dropped by about 34% worldwide between 2000 and 2020, every day in 2020, almost 800 women died from preventable causes related to pregnancy and childbirth. A maternal death occurred almost every 2 minutes in 2020. Almost 95% of all maternal deaths occurred in low and lower middle income countries. However, between 2000 and 2020, South Asia achieved an encouraging overall reduction in maternal mortality ratio, a decline of 67% from an MMR of 408 down to 134. And the event today will focus on harnessing lessons learned in the region to accelerate reduction in maternal morbidity and mortality. As Nepal, Bangladesh, Pakistan, and Sri Lanka transition to a middle-income country category, it is hoped that access to universal maternal health care will improve through targeted investments focusing on the population who are left behind. And for this, we have government representatives from all of these countries present here for a panel discussion. So before we go to the panel discussion, may I invite the Joint Secretary, the host of this side event from the Government of Nepal, from the Ministry of Health and Population, Mr. Ramesh Kesi, to kindly take a seat here and deliver his opening welcome remarks. Thank you, sir.
Thank you. Good afternoon, ladies and gentlemen. Thank you for joining this side event today, which is organized by Government of Nepal, Ministry of Health and Population, and UNFPA and other stakeholders jointly coordinated. I would like to welcome you all from the Ministry, the government official from Bangladesh, Pakistan, Sri Lanka, and I would also like to welcome our Deputy Executive Director for Program UNFPA and all CSO members and all delegates and dignitaries who are in this hall. I would like to welcome you, and we will discuss 1 and more hour in this sideline, and we will discuss in the maternal mortality reduction strategy in the South Asia region, how we are doing better in comparison to the previous year, and what are the learning, we exchange our learnings in this region. Thank you very much for joining, and I would like to hand over Bandana. Yes.
Thank you so much. Thank you so much, sir, for that opening welcome remarks, and particularly thank you for the government of Nepal for initiating this side event at this very important juncture of cross-learning so that we can accelerate progress in South Asia. So thank you to the government of Nepal as well. And with that, we have with us today the Assistant Secretary General, Diana Kete, the Deputy Executive Director for Program of UNFPA. It's very, we are very honored to have you here in this region. That shows how much of importance you have for this region as well. So, Madam, may I request you to please deliver your opening statement? Thank you.
Thank you so much, Madam Chair. Always a pleasure to see you.
Thank you.
Whether here in Geneva. Good afternoon. I would have said good morning, but I'm following the chair. Good afternoon, Excellencies, distinguished guests, participants from the Ministry of Health, UNSCAP colleagues, UN agencies, dear colleagues from UNFPA, dear friends, it's a pleasure to be here today to deliver the opening remarks at this important side event on maternal mortality reduction in Asia Pacific. Ending preventable maternal mortality by 2030 is a transformative result that UNFPA committed to globally in its strategic plan, and we are encouraged by this initiative of countries to come together to learn from each other and make every effort to end this tragedy for women and girls and for families. We are grateful to all of our partners in Ministry of Health, as well as to the UN, United Nations, to the CSO's partner, midwives, nurses, doctors, who strengthen health system, improve the quality of maternal health services, and find ways to address inequities in access to care, all in a concerted effort to drive down maternal and newborn mortality rate. Ending preventable maternal deaths remain unfinished business in the Asia-Pacific region. Other 6,000 women are estimated to have lost their lives during pregnancy and childbirth in Asia-Pacific in 2020. That's what you said, two women were dying every 2 minutes. Southern Asia in particular accounted for over 45,000 of those deaths, despite a significant 67% reduction in maternal mortality ratio since 2000. From the bottom of my heart, I'm a woman and a mother, I commend the representative of the countries here today, Bangladesh, Nepal, Pakistan, and Sri Lanka, for organizing this important event aimed at sharing best practices and lessons learned in maternal mortality reduction in order to reach the SDGs target and goals. No woman should be dying while giving birth. We have been able to see excellent effort by each of your countries in different ways, and that are now realizing dividends. The Prime Minister of Bangladesh made a commitment of 3,000 midwives by 2015 back in 2010 at Every Woman, Every Child initiative during the United Nations General Assembly. This brave commitment has resulted in huge improvement in quality of care for women and newborns, a cadre of midwives dedicated to providing care to women and girls. The whole region is here to learn from you. Nepal has made huge strides in implementing an action-oriented and localized response system to deal with every maternal and perinatal death. This system of accountability is critical to help facilities, local level communities prevent repeat death from the same causes. We commend you. Pakistan, you have also made great commitment to strengthen your workforce of midwives and ensure that those women in the most remote part of the country are not forgotten and can access care. Thank you. Sri Lanka, we look to you as one of the few countries in the world who has maternal and newborn mortality rate below the global SDG target. You have always guided the world with your strong public health system, high quality care available to all people. This is the foundation for a healthy and prosperous society. Please continue to guide us. Your effort, your advocacy, your increased investment in strengthening the quality of care for all pregnant women and girls, your efforts to ensure that every woman has a skilled provider at her side for her delivery with access to life-saving drugs, no matter how isolated she is or how vulnerable she is, will make a difference. Thank you all. Improving maternal health and driving down morbidity and mortality are essential to health system priorities, critical to the realization of the sexual and reproductive health and rights of women. We cannot advance gender equality. We cannot help nations advance when we have women dying in pregnancy and in childbirth. As many of you will know, the United Nations Human Rights Council adopted several resolutions on preventable maternal mortality and morbidity and human rights. The Council urged all states to renew their political commitment to eliminate preventable maternal mortality and morbidity at the local, national, regional, and international levels, to strengthen their effort to address multiple and intersecting inequalities, and to allocate domestic resources to health system and the provision of the necessary information and services in relation to the right to the highest attainable standards of physical and mental health, including the sexual and reproductive health of women and girls. In this respect, Excellencies, dear friends, I'm grateful for the attention that member states, that you are dedicating to the issue of maternal mortality. And I encourage you to make this investment in health systems that have proven to be working. UNFPA stands with you and beside you to offer you the technical assistance you may need to this end, this tragedy together. I thank you for your kind attention.
Thank you so much, Deputy Director Diana Kete, for highlighting and acknowledging the positive progress made by the 4 countries present here in reducing the MMR and the different spectrums of SRHR, let's say. But also your emphasis on the need for continued collaboration and collective action to move forward. So I think that's a very conducive opening statement, that precedes our panel discussion that's going to take place now, because it's exactly about those successful lessons learned and how we can work together in the future also. So thank you so much. With that, before we go into the panel discussion, we would like to present a quick snapshot of the status of maternal health in Bangladesh, Nepal, Pakistan, and Sri Lanka. And to do this, may I request Catherine Preen Kamkong, the Regional Advisor of SRHR in UNFPA, for making this presentation. You have 8 minutes, Catherine. Yeah. Madam, would you like to sit there, because you'll have a better view? Yeah. Yeah.
We are innovating as we as we go. Just move like that. To our Deputy Executive Director of for Programs of UNFPA, to Diana Kete, to distinguished members and guests from Nepal, from Pakistan, from Sri Lanka, and from Bangladesh, to CSOs, to UNFPA colleagues, thank you for inviting me to give this little snapshot and presentation about the situation in our region. I think that Diana and colleagues have already given you a little bit of that information, and I don't want to take up the time that we need to spend today finding the solutions. But what I wanted to just show you is that in our region, we still, and so not only your 4 countries, but in our region, we still have a huge unfinished agenda in ending preventable maternal deaths. While we've been here for 3 days in these meetings, we have lost nearly 200 women. And that is an unacceptable tragedy and reality that all of us are here to fix. So as you can see, we contribute hugely in terms of our MMRs have come down, but the absolute numbers are really staggering. Now, we've just made a little graph to show how the 4 countries, Nepal, Bangladesh, Pakistan, and Sri Lanka, have made great progress, but we're hitting a stagnation and we really need to accelerate. If we look on the left here, we did some calculations with my wonderful colleague Federica here. She helped me work out how, if we keep going at this rate, how long is it going to take us? Because we're in a rush. We cannot, slow down. So we have Bangladesh if you keep going at this rate, and this doesn't take into account COVID, you have 9 years and you will hopefully reach your target. Pakistan, 12 years. Nepal, 13 years. And Sri Lanka, who already had a low, below the SDG target, but your commitment is to a 2/3 reduction. So you are going until 2062 if you go at this pace. So we know that if we improve antenatal care, that we bring down mortality of mothers and babies. And it's what we can see is that's improving in all countries. We're not talking about number, we're not talking about quality, but you know, we're seeing an improvement. Now we look at institutional delivery. We still got a lot of women having babies at home without a skilled attendant. Sri Lanka, look at them, nearly at 100, and look at their MMR, right? No woman deserves to be at home without care, without drugs, without a midwife at her side. It is frankly unacceptable in 2023. So why are they dying? Why are women dying? I'm not here to reveal some new, amazing cause. They are things we have been talking about for many, many years. Women are dying of complications in pregnancy and birth, and they're still the same ones. Bleeding, infections, high blood pressure, complications in delivery, and unsafe abortion. Now, the difference that's happening is that more women are reaching the hospitals and health facilities, but poor quality care is actually killing many women. So we have to not only work on getting them to the facility, but we have to work on the quality of the care. So these things that we've learned globally, we have to invest in health systems. We have to eliminate all the delays within a health system. You know, we have to make sure there are drugs and supplies there. We have to have staff, we have to have midwives, and we have to have referral systems. We have to eliminate those delays in women seeking care. Women have to have power and autonomy to say, please, can we spend that little money that we have to let me go to the hospital and have my baby? Please, you know, we need to reduce this out-of-pocket expenditure. So your countries, your governments, we need you to invest in making sure that the poorest woman doesn't have to sacrifice her house, her land, just to go to hospital and have her baby. We have to target these pockets of inequities. I was reading today, Papua New Guinea, if you're a woman in a village, you are at least 8 times more likely to die, you know, than a woman in an urban center. And many of you have got very rural places, right? So we have to target these inequities in our countries. And finally, avoiding this over-medicalization in our region, too much too soon and too little too late. It's the true reality. Some women are just going and having elective C-sections, and another woman who's dying because she can't get any care. Okay, so we know that investing in midwife, I'm just going to tell you 3 evidence-based strategies that we can invest in. One is investing in midwifery, improving midwifery. Midwives can deliver 95% of the care that is needed in sexual and reproductive, maternal, newborn, child, adolescent health, a big scope of work. And they really, if we invest in training them, educating them, deploying them, we will really reduce mortality significantly. Of mothers, it's a massive, you get a triple, what do we say, dividend. Mothers, newborns, and families. Okay, strengthening emergency obstetric and newborn care. We still see in most countries, including sadly your countries, when a woman experiences a complication, she doesn't have access to that critical care that she needs to save her life. So UNFPA has got a lot of technical expertise in this, and we want to help you with that, making sure that you can provide that in the way that is needed. Accountability for every single maternal death is critical, and we have learned that these maternal and perinatal death systems are really important. It tells us who is dying, where are they dying, and why are they dying, and it gives an opportunity to each local facility and district to make a response. That response is the accountability, that's the action, that is the commitment to the woman that died, that we will not let this happen again. So please invest in those systems, in MPDSR. It is critical to stop the repeat deaths. So, and finally, we have to address other contributing factors. So social determinants, in those that are poorest, those that don't have education, different ethnic and racial groups are at much greater risk. We have harmful gender norms and or inequalities that really result in low prioritization rights of women and girls. And finally, we have this instability and fragility that is caused through things like climate change and the natural disasters and conflicts, sadly, that are prevalent in our region. Okay, I'm going to skip this and I'm just going to finish by, there was this most wonderful, inspiring Professor Mahmoud Fatallah. He was an Egyptian obstetrician, and many years ago he made these wonderful films about why did Mrs. X die. Maybe have a look at them. The sad thing is that not a lot has changed. But he said, women are not dying because of diseases we cannot treat. Like I told you, we know the problems and we actually have a solution. It's a rare thing in the world today. But women are dying because societies have yet to decide their lives are worth saving. So please, and I really ask all of you, please invest. Let's do everything we can to end this tragedy in all of your countries. And UNFPA, we stand with you, beside you, and we will help you. So thank you.
Thank you so much.
Thank you so much, Catherine, for presenting that excellent snapshot in a short time. I think you presented the accelerators, the enablers, where things need to be scaled up and which country needs to learn from whom, and that's exactly what we are talking about today, the cross-learning, on this aspect. So for the panel discussion, to hear from the countries, the successes that they have made and the lessons that we can all take away from here, I would like to invite our dignified, honorable representatives, the speakers from each of the countries, Bangladesh, Nepal, Pakistan, and Sri Lanka, to kindly please come up and take your seat here. Thank you. Thank you, Madam. I think we can do it alphabetically. So Bangladesh, yeah. Nepal, Pakistan, and then Sri Lanka. We have two people from Pakistan. Please, thank you. Do we have enough seats? Yeah. Thank you. Thank you so much, Excellencies. We are all eager to hear from you, the success stories that you have today. And I would really like to request you all, because time is of constraint here and we are providing 4 minutes to each country. So please kindly focus on the exact success that has been made and what are the key, why it worked, what are the key components that made it work. That would really serve the purpose. So I would like to start from Bangladesh. And from Bangladesh, we have Honorable Sahan Ara Banu, the Director General of Family Planning, Medical Education and Family Welfare Division, the Ministry of Health of Bangladesh. Investment in the health workforce, especially midwives, education deployment and regulation is one of the key drivers of maternal mortality reduction through improving access to skilled birth attendants and emergency obstetric care, as Catherine has also just presented. Bangladesh has made significant progress in reducing maternal mortality through deployment of a large number of midwives. Could you please share how you were able to achieve this major progress in health workforce development, especially in the case of midwives? And Madam, you have 4 minutes, please. Thank you.
Thank you so much, respected Chair, Excellencies, ladies and gentlemen, very good afternoon to all. Bangladesh has made a remarkable progress since International Conference for Population Development 1994, when in line with the global trajectory of achievements. Bangladesh progressed through people-centered approaches focusing on human rights and women's empowerment has reduced the fertility rate from over 6 in 1975 to currently 2.15, and in reducing maternal mortality ratio from 375 maternal deaths per 100,000 live births in 1994 to 156 in 2022. In Bangladesh, 65 deliveries occur in facilities. Moreover, 70% of deliveries were attended by a medically trained provider. A series of training of emergency obstetric care, family planning, cervical cancer, maternal perinatal death surveillance and response regularly held under the Ministry of Health and Family Welfare to increase the capacity of the service providers. Unless the public health facilities with adequate infrastructure provide institutional deliveries through the qualified and trained cadre, the doctors, midwife, nurses, paramedics, and family welfare visitors at the village level. But country's SDG target is bringing the maternal deaths to 70 per 100,000 live births will not be achieved. So, Ministry of Health and Family Welfare has started investing on the midwives for the quality education and training. The Ministry of Health and Family Welfare initiated the development of professional midwives in Bangladesh. In January 2013, a 3 years diploma in midwifery programs started in Bangladesh. Currently, 5,705 students are getting admitted in 62 public and 108 private institutions. Total number of registered licensed midwives at present 7,230. In service, BSc in midwifery 2 years has been started in 2020 in 4 institutions with 80 seats, and curriculum has been drafted to start in-country master's program in 2025 in the 2 nursing and midwifery colleges approved by the Ministry of Health and Family Welfare. 3,000 posts of midwives has been created in 2010. Total number of government deployed midwives is 2,557. Recently, 5,000 midwifery posts have been created in 2022, and at village level, government is planned to recruit FWBs at the village level or union level infrastructure, where we have 3,500 US and FWC, or the Union Health and Family Welfare Centers, where we want to ensure 24/7 service delivery. So we have designed to recruit 7,000 midwives to operationalize that 3,500 US and FWCs. Midwives are well trained to offer other sexual and reproductive health care services like family planning, cervical and breast cancer screening, identifying obstetric fistula cases, offering STI, HIV services, including health sector response to gender-based violence. Their system development in the next 5 to 6 years cannot only help Bangladesh achieve SDG Goal 3 on maternal mortality, but also many other health-related goals and targets, with a significant contribution to other social sectors targets under SDGs. This will also be instrumental in progressing Bangladesh confidently towards attaining universal health coverage, particularly comprehensive SRHR services. Some of our achievements are behind the story. We have set model union, that means village level health and family welfare center initiative to increase institutional delivery, and they are actually operationalize our vaginal normal delivery and ensure 24/7 service delivery at the facilities level, phase by phase scale up. Rapid development of midwife at union level health facilities, emphasis on postpartum family planning, focused on family planning, implementation of Robson classification and risk mother identification strategy, hard to reach area focused strategy, more focused on safe MR and post-abortion care and prevent unsafe abortion, automation of health facilities and boost to telemedicine, service purchasing and task sharing in resource poor areas, development of action plan on the National Clinical Mentorship Program to improve quality health care in resource poor health facilities. Thank you for giving me the opportunity.
Thank you so much. Thank you so much, Madam, for your presentation. And I think some of the enablers that you pointed out that I could gather, and I'm sure there were more, is in the progress that you have made in safe deliveries are perhaps adequate infrastructure establishment, capacitated and adequate human resources, education and training, and reaching the furthest, the strategies that you have applied for reaching the furthest. So now I go on to our next distinguished speaker, who is from Nepal, Mr. Ramesh Kumar Kesi, who is the Joint Secretary at the Ministry of Health and Population. And to you, sir, the 2021 Nepal census included data on live births and deaths of women of reproductive age. This methodology provided evidence for determining the causes and distribution of maternal mortality, both at the national and subnational levels. Since obtaining reliable representative data for evidence-based decision-making is a major challenge for many countries, and Nepal being one of the few countries to produce robust data at the national and provincial levels, could you please share how the survey was embedded in the National Census of 2021 and the collaboration with different government line ministries and stakeholders? You too have 4 minutes, sir.
Thank you, distinguished panelists and all of the participants. Yes. Nepal, along with the National Census 2021, has conducted the total enumeration of maternal mortality census, and that has produced the result. While we're talking in the evidence-based planning and evidence-based decision making, the data, significance of data is very important. And we did a historical event with collaboration of all stakeholders. While obtaining the data, inferring the data, we have historically conducting this enumeration. In every 10 year, we conduct our census, and 2021, all enumerator has indicated where the maternal mortality incidents are occurring, and our health personnel are capacitized and they are trained to conduct the maternal mortality situation. After the marking where the incidence is, and the trained health personnel are conducted verbal autopsy, and as we have find the data. The data number is also significant, but the methodology, how we conducted, is more important, I think, because always we did survey, we collect the data from administrative records. These are often controversial and sometimes are not valid, but this is the first time in history, and it's kind. We did all enumeration that gives us a strong database for our decision making, for our health planning, for our health program. This gives us a lot of data, and where we focus in the coming days, this is the evidence for us. And the coordination among the stakeholders is most important. Among the government agencies, in the federal and subnational level agencies, and the development partners is also most important thing while conducting this enumeration. First, we have a memorandum of understanding with the Ministry of Health and Population and National Statistics Office. The Statistics Office conducts the census, and then we have coordinated with other government agencies as well as the development partners for technical support and other necessary requirements. With the effort of all stakeholders, we have conducted this maternal mortality census, and we obtained that the 151 maternal death occurred for 100,000 live birth. This has a tremendous result in our perspective, in our situation. This is a good example of collaboration and coordination among the stakeholders, and I think this initiative has lesson for other gaps what we are facing for the coming days. Thank you.
Thank you so much, sir, also for keeping the time. We all know how important data is, evidence-based data for decision making, but that's the biggest bottleneck in many countries. And me being in CEDAW, I know that in the CEDAW committee, we continuously ask state parties. There's a lack of data all the time, especially sex disaggregated data in all aspects. So in this presentation, I think one of the strongest points is leveraging the national process, the census process, to get this reliable data that we have. And I think he strongly pointed out the enabler being the coordination, the collaboration, and the correlation among all stakeholders, particularly other government agencies, as well as development partners, maybe civil society as well. Perhaps. I mean, I would like to believe, I think the civil society was also involved there. So this is the most important enabler over here. And of course, the methodology, as well as the training of enumerators, the selection of enumerators. From this, we move on to Pakistan. We have two distinguished speakers from Pakistan, Dr. Nigina Khan, who's the Director of Ministry of Health, and Mr. Kamal Shah, who's the Chief Executive Officer of Family Planning Association of Pakistan and focal person for IPPF. Pakistan has become a good example by embracing the Universal Health Coverage Package to ensure essential health services reach the entire population. Could you please highlight how maternal health issues have been addressed as part of the Universal Health Care Package, including the expansion of emergency obstetric and newborn care? Both of you have 2 minutes each, please. Thank you so much.
Thank you. Thank you so very much. I'll be presenting and then our colleague from the ministry will be concluding it. So we all know that Pakistan is the 5th largest country in the world. Since ICPD, we have made significant progress because if you recall, in 1994, our maternal mortality was 521, which has come down to 186 in 2019. The neonatal has come down to 41 per 1,000 live births. But we are still among the countries which has the highest maternal mortality within the region. And if you look at the data, the maternal deaths due to obstetric hemorrhage has gone up to 41% from 33%. Maternal deaths due to abortion-related complication has gone up to 10% from 6%. So despite our progress, there are areas and pockets that we need to work on actually. The contraceptive prevalence rate in Pakistan and unmet need remain stagnant for over a decade in Pakistan, and we have been struggling with it. The government of Punjab, which is our province, 54% of today's Pakistan is in Punjab, which is half the country. They basically started EMOC services and they selected a couple of districts. If we talk about Punjab, it is 54% of the population and 63% of Punjab lives in the rural setting. Basic health unit is the first point of contact facility for any population, but it is only a single bedded facility which has a doctor, male or a female doctor, and they are basically supported by paramedical staff, and we have obstetric services are basically provided by mid-level providers. And in some clinics, they do have the mid-level providers, and some of the clinics, they don't have the mid-level providers. And as such, the entire EMOC was not actually, the government was not in a position to take the comprehensive EMOC services to the population. And as such, only basic EMOC services were introduced in a couple of districts in Punjab. Despite of the basic EMOC package, the results were remarkable. Facility-based deliveries went up to 72% from 33%. Deliveries conducted through skilled birth attendant went up to 71% from 38%. Newborn receiving postnatal care within 2 days of delivery went up to 5% from mere 2%. Mothers receiving antenatal care from skilled provider went up to 72% from 51%. Mother receiving postnatal care from skilled provider went up to 63% from 25%. So what were actually the reasons behind such a success and such a remarkable results coming in? Some of the key interventions that the government of Punjab did was capacity building of human resource, provision of additional medicine and supplies. There was a key element which actually turned the entire program, and that was provide free of cost pick and drop facility to all pregnant women calling for a delivery to any nearby public sector facility. And even for the referral, they were provided free of cost pick and drop to the referral point and then back to their home. This actually worked as a key element in the entire process. There was also another element which came for the very first time in the government of Pakistan was flexible fund. In the government, I've never heard word flexible funds, but this was the very first time when there was a provision of flexible funding to health councils to improve availability of clean drinking water, cleaning and comfortable waiting area, clean and tiled labor room. So these are some of the provisions that actually gave such good results. But there were also a couple of challenges. Staff availability has been a big challenge. Financial constraints were there because if you need to improve in a facility, if you need to bring it to a level for the quality of care standards, the financial was a big problem. Then there also was another challenge was noticed during the project and during the entire intervention was delay in decision making by providers for referral. At times, that delay had actually caused to the problem. If a timely decision was made by the service provider, it could have saved the woman's life. And then the cost relevance for the client, because at times you had to send them to a private clinic. And the private clinic cost was never counted during this entire process. Where from the client will pay those costs? Because we are talking about rural setup. We are talking about people who can't pay. And we are also talking about a community where family planning and the entire package is provided free of cost by the government. What is the next step that the government of Pakistan did in this scenario? To maximize from the learning from Punjab and also to ensure the SDGs are target with assistance of UNFPA, Ministry of National Health Services for the very first time initiated comprehensive EMOC need assessment study. This is the first of its kind in Pakistan. It had to be completed in 3-phase manner, and the third phase has just been completed in third quarter of 2023. About 25 trainers have already been trained by the public sector through consultants and with assistance of UNFPA. These studies are likely to highlight staff capacity, infrastructure, equipment, supplies, delays, staff attitude. And if we are not really able to work on all these areas which are identified through these studies, we may not be able to ensure quality of care and quality of services. And if you don't have the quality, I'm sure, have I taken more than my time? That's okay. I'm sorry. Yeah. So actually that with this intervention, we assume that once these are covered, the result, and we would be able to go to comprehensive EMOC services as well, which is the need of the country. Apart from this, there was another strategy which was adopted with the assistance of UNFPA. We have already completed the clinical protocol. With the assistance of UNFPA, the clinical protocol has been completed and are in place now. And we also initiated another task sharing and task shifting. So mid-level providers are actually trained on long-acting reversible contraceptives so that the burden on the medical doctors can be shared. Over to you, ma'am. Sorry for taking longer than I was supposed to.
It's okay. I'll not take that much time. I just would. Good afternoon, everyone. I would just endorse the statement given by Kamal Shah in his presentation. Pakistan is utilizing both national and global best practices. National best practices in the context of basic EMOC services already implemented in some parts of Punjab, as already mentioned by Kamal. And global best practices of utilizing long-acting reversible contraception in the shape of task shifting and task sharing to assist medical doctors in their responsibilities regarding contraception by involving mid-level service providers so to shorten their burden. We are fully committed towards universal health coverage and hope that we will meet our SDGs target well in time. Inshallah. Thank you.
Thank you to Pakistan for sharing that success on EMOC services. And particularly, again, may I just highlight some of the enablers. I think, again, it was capacity building of human resources and adequate human resources. What was interesting was the funding, flexible funding. As you said, governments never have flexible funding, but this was very interesting to hear that, which enabled adequate supplies and medicines as well. And then the enabling environment and infrastructure, enabling environment, because you said it was clean and everything, you know, so the free services for pregnant women and the need assessment study to guide the way ahead. I think these were some of the enablers from your presentation. We now move on to Sri Lanka, and we have Dr. Asela Gunawardena from Sri Lanka, who is the Director of General Health Services. Sri Lanka's remarkable achievements in maternal health are considered an exemplary success in the region and beyond. What were the key driving factors behind this globally acknowledged progress, and what are the challenges you have faced? Thank you, sir. 4 minutes.
Thank you, Chair, for giving this opportunity. I think Sri Lanka has achieved a remarkable achievement on maternal mortality and infant mortality reduction. Our maternal mortality rate is 29.5% per 100,000 population. It is below the SDG level achievement. The most remarkable and the most valuable intervention that Sri Lanka has done from past is the introduction of our strong public health system and introduction of this midwife in the field level to look after the pregnant and child. Our MCH care model is the most innovative model in this region. We start this maternal and child care from the marriage, and midwives we have the whole country was divided into 354 medical office of health area. This one health area is manned by a medical officer of health who is a master in the public health, and under him there are midwives according to the population. The one midwife is having about 3,000 to 5,000 population, so each midwife is knowing by name each and every person in her constituent. So he visit every day for their houses, and they get all these marriage couple, and then they enter into the eligible couple registry, and then they start doing the family planning and counseling, and then they prepare these mothers for their antenatal and pregnancy. And during the antenatal and the intranatal and postnatal, all these care were given by the midwives. And what we have done was the public health was actually coupled with the curative care services. Wherever you get admitted, the emergency obstetric care is available throughout the 24 hours, 365 days. This is the vital, it is available. Even in the smallest primary care health institution, the basic emergency obstetric care is available. That is where we have got this reduction of maternal mortality rate. And other thing is our surveillance system. This each and every maternal death is we are having a surveillance. It is institutional level, district level, and lastly the national level. So it is not a fault finding mission, it is a fact finding mission, and it is now we have converted it to a confidential maternal death inquiry, because we don't want to reveal any names and other things. So they are very all the consultants and up to all the other staff members are very pleasant with this confidential inquiry. So each and every maternal death is inquired, and each and every maternal death has to undergo judicial postmortem. So the cause of death has to be given. So there can't be any maternal death without any cause of death in our country. So each and every maternal death we are going to review, and we are going to find the cause. Now we are having actually most of the direct causes we have eliminated, but we have the indirect causes coming up. So that is the real challenge for Sri Lanka.
Thank you so much, sir, for presenting the successful MCH model. And I think, again, here the accelerators are, as you said, the one-to-one, house-to-house communications. And the survey, in many countries we have policies and plans, but we never go back again to survey to see what has worked and how we can amend those. So I think that was a very interesting factor here, where you said you have this this review and this fact-finding mission. So that was, I think, I particularly found it interesting, and I hope the audience here also can find some learnings from these presentations as well. Thank you once again to all the panelists. We have around 20 minutes, yes. We have around 20 minutes, so I think I will open the floor for any specific queries, observations, questions. We will take around 3 to 4 questions and then revert back to the panelists for their responses. I first saw over there, and then you, then you, then you. Okay.
Thank you so much. This is SM Shrikot from Sirak in Bangladesh. I'm so glad to hear from the 4 governments and their interventions, and as civil society representatives and those associated to the government initiatives, we do recognize a lot of progresses, but at the same time, there are spaces where we need to work together. I just want to mention a couple of progresses which are also associated with the civil society advocacy that includes the introduction of midwifery services that the Director General mentioned. It is very interesting to mention that 86% of the child deliveries in 407 sub-districts across the country is now managed by the midwives in just 1 decade of introduction of this program. This is a great success since the APPC 6. Another thing is to achieve SDG 3.7 and target 5.6, the government should, I feel it should also emphasize more on providing universal access to family planning commodities to adolescents and young, irrespective of their marital and the background and other statuses, because this is very important to achieve the SDG targets that ends in less than 7 years. So we have a lot to go together, but at the same time we need to work together to make this happen. And I convey this to the Director General present here, and I hope that back in country UNFPAs and DGFP will work together to make it happen. Thank you so much.
Thank you for that civil society voice from Bangladesh, adding to the government presentation and the emphasis on working together, civil society government partnership. You, sir, yes.
Yeah,
Please introduce yourself also.
My name is Razik, and I represent an organization called College of Youth Activism and Development. But I've been also working as a technical expert with some of the organization that has been supported by UNFPA. And one of my, I just want to flag 2 enablers, Madam Chair, you are referring, and one is the at the small scale, the UNFPA in Pakistan has introduced the concept of psychosocial support to the women who've been going through maternal health crisis. And I visited far-flung areas in KP and Sindh and realized that the young graduates that has been installed as part of the BHU at the village level are overwhelmed with the stories and breakthroughs that they have been sharing, that how they with their psychosocial support, how they are enabling women, particularly who have been going through the crisis. So I just want to highlight that that is one of the significant element that needs to be part of the programming, whatever you've been doing. And the other was the transforming the social structures and engaging men, particularly and boys, to realize that how their role as parents, as men, are important to enable women to access the services and be treated well when they've been going through these processes. So these 2 elements.
Thank you for recommending those 2 very strategic suggestions for add-ons, particularly engaging men and boys as well. Yes, and then you.
Hello everyone, this is Medha Sharma and I lead a young women-led organization in Nepal called Visible Impact. So while discussing the maternal mortality, two factors that are not on the very top of the chart, but they are still there on 4th and 5th numbers. At least in Nepal, I know because of the maternal mortality survey that Ramesh sir just presented. Is one is safe abortion, because it's 20 years, more than 20 years that safe abortion has been legalized in Nepal, and it's still free of cost. Yet it stands as one of the leading cause of maternal mortality in Nepal. But another factor that is not discussed much but is rising sharply is self-harm during pregnancy, because women are, because of the hormonal changes, psychological changes, self-harm still accounts for 6% of maternal mortality in Nepal. So I think it's a food for thought for all of us that these two factors are rising sharply in the charts. Thank you.
Thank you so much, Medha, for adding that valuable thought. You and then you. Please introduce yourself as well.
It works. Good morning. It's not good morning, it's afternoon, I believe. We have just lost the time and space. Sorry for that. So my name is Shakil, and I am Chief Population and Planning Ministry. And I would like to share my stories when I was Program Director for Health, and I was looking after the BHUs of whole of the KP. So, and we were looking for the best lesson learned, and in the region especially. So Sri Lanka was always, at the top of the list. One of the reason being it is the population is small as compared to the other countries. And as Honorable DG has mentioned that, 3,000 population of a midwife, which is, a midwife could remember the names of each patient, I'm sure. But in Pakistan, I would say 25 and 30,000 for one midwifery. I mean, it's impossible to reach. So, and if you go to the northern part of Pakistan, which is Chatral and northern areas, the BHUs are quite far. I mean, if a patient, would come, if you would make her to an hospital, it will take days. Not a day, an hour, days. So the best thing what I did was that and another thing which Kamal mentioned was the flexibility. Yes, this is the key. The problem with the government everywhere is that you've got stringent rules. You cannot come out of the rules, and if you just come out of the rules, saving life is not that important as the rules are. So I mean that's how it is. So the flexibility, I had the flexibility. What I did was I bought portable ultrasounds, and midwife were low level educated. I mean not necessarily a doctor. So they were trained just for the position of the baby, and they could see, and if there was any danger that your position of the baby is such that you would need a C-section. So the patient was told in advance that you must plan and go to the hospital somewhere where you can have a C-section. So this kind with this, and with ambulances, and ambulances are, it's not easy to buy ambulances in countries which are. We had some ambulances which were just standing, and they were just out. I somehow maintained them and just took it to the far flung areas, and like I tried to reach to the community. So this is very important that either you reach to the community or community reaches you. So this is an important lesson for us, that flexibility and secondly, we should have a private public partnership model. Otherwise, for countries like us, it's not possible to have line with it. Thank you very much.
Thank you. Okay. We only take two more now, one you and one Dr. Renude. Very brief, please.
How can regional collaboration and international partnership contribute to the development and implementation and initiatives that address the specific reproductive health needs of women in Asia, particularly those who are vulnerable to physical violence, ensuring a collective and impactful response to these challenges?
Okay, that's a very broad question for the panelists over here. Dr. Renu, yes.
Can I, thank you very much. Thank you all dignitaries for excellent presentation. I just wanted to add, kind of enablers. I am a public health person and human rights activist. So kind of enablers for Nepal is FCSB played by the government, and then that is making huge difference, right? So and like, okay, civil society also played very important role to raise awareness and then to bring this. These are some of very positive aspect, and then I can go on. There are a lot of positive things in Nepal which has been taken by the government of Nepal to very progressive laws are also there, Safe Motherhood and Public Health Act. But in spite of that, kind of there are a couple of areas where we really think that, okay, we need to add things like, okay, one thing, if we really look now, maternal mortality, genderless violence is one of the key, to contributor to maternal mortality, right? And within that, the issue which is really bothering us is like young girls, 13, it's not like, okay, they have not even counted as a maternal mortality, 13-year, 14-year out of incest, getting pregnant, rape, getting pregnant, and then dying. So this is one of the issue, like we who run Safe House, we are facing, and the one like, migration is playing very important role. I think these are the indicators which we cannot avoid, we need to discuss and we need to bring into the forefront. So that's what I really wanted to bring on the table. Thank you.
Thank you. Thank you so much, Dr. Renu, and thank you to everyone who added the enablers. Particularly, I like the fact that most of the civil society who spoke also added positive enablers and the collaboration for government and civil society partnerships and the public-private partnerships as well. Before I revert back to the respondents, the panelists, for 1 minute, perhaps 1.5 minutes each, I would like to acknowledge the presence of 4 UNFPA country representatives here who played a key role in organizing this side event. So could you please stand up, sir, from Pakistan? Yes, Christine, yes, and yourself, Young, yeah, and from Nepal we have, Young. So a big hand to all of the 4 of them. Thank you so much. And now I revert back to the panelists for your responses. I mean, there wasn't much responses that we expect, but an overview of what has been asked and what has been added. Madam, yours.
Thank you so much, madam. I would like to mention 2 points. One regarding home visit by the midwives. In our country, we have around 55,000 staffs in our family planning sector, and one category that they are working at the grassroots level, family welfare assistant, they are ladies, and union level, every ward we have one staff who are visiting the houses, all houses of that respective areas, and taking their informations, collecting all the information about adolescent girls, pregnant mothers, and newlywed couples, etc., and convey these reports through EMIS. So we are getting information instantly. And another point raised by Siraj Bangladesh, service for adolescent. In our countries, around 50% girls are getting married before 18, and they are become pregnant before 18. So we are providing service for the adolescent also. We are ensuring about the service, ensure no intended pregnancy occurred, and every mother covers by our services, antenatal checkup, postnatal checkup, and also facility delivery. We are ensuring to ensure the safe deliveries. So thank you.
Thank you so much. Nepal.
Thank you.
Thank you, ma'am. Thank you for the feedback we received. Yes, in our detailed report, there are mentioning what are the reasons behind our success story. As already Medha said, there is a safe abortion initiative from a decade-long effort in Nepal that has played a significant role to reduce the maternal mortality. Also, Renu ma'am has elaborated some FCSB's role to reduce the maternal mortality. Airlifting like of initiative has also played a vital role in reducing maternal mortality, but there is still a long way to go in Nepal. This is a big challenge to reduce more because it is 151 is very huge in comparing to other country, but we have made paved the way to move the vehicle. That is the database we have prepared, and this is only been success by the collaboration and cooperative with all the government and non-government stakeholder and development partners, and we are supposed to continue with these efforts. Thank you.
Thank you, sir. Pakistan.
Thank you for giving opportunity again. I would like just to appreciate the role of civil society in achieving these goals. And I would encourage civil society and especially the youth to keep sharing best practices and do proper and positive utilization of social media so that we can learn from each other. Thank you.
Thank you. Yes, Sri Lanka, please.
Yeah, yes. I think before I recapture from Sri Lanka, regarding one questions raised here regarding the gender-based violence. In Sri Lanka, we have a system in each and every hospital. We have set up a unit called Mitrapis. That is, any adolescents or any mother, any women can walk in, and there are counseling services are available for the gender-based violence or any other matter. So it is during working hours, it is freely available. There is specialized doctors and nurses who are trained in this subject, and they any person, any citizen can utilize. That is, our health system is free of charge, so anyone can walk in. So even though Sri Lanka had achieved this remarkable position, even still we are having challenges with us. That is, gaps in our quality of care, and these over medicalization of the childbirth. There is very high seizure rate. It's a huge problem for us, and these out migration of our skilled health workers, it is a big issue at the moment. So now I have to thank all, it is the government as well as all the UN organization and the community-based organization and the non-governmental organization, because we all work as a group to achieve this target. Thank you.
Thank you so much to all the panelists for keeping the time and showcasing this compelling picture of success. However, we all know that there are substantial challenges in the region that persist, which underscore the need for continued and accelerated efforts and collaboration to overcome obstacles. And I hope that this event will help to initiate a regional learning and support platform for accelerating the reduction of maternal mortality rate in the region. I thank you all for being here and your engagement. But before we end, I would like to request a delegate from Nepal, Sangeeta Shrestha, who is the Chief of the Nursing Administration of the Government Hospital, Bir Hospital, to deliver her vote of thanks.
Thank you, Madam. Distinguished delegates, esteemed our panelists, and all of you, good afternoon. I would like to take this opportunity and pride to be a co-host of this site event, which is focusing on the maternal mortality rate reductions. And a developing country like Nepal has deal this maternal mortality problem with the healthcare services availability and with the accessibility of health services. So this panel discussions is a great platform to learn about our best practices from all of the 4 countries and to reduce the maternity mortality rate and to make the maternal health in progress. So reducing maternal mortality rate and presenting these all several obstacles like 3 delays is very important in our country like Nepal also. So we have deliberately empowered our health facilities and in context of combating the maternal mortality, and our effort has included several aspects like ensuring the availability of qualified health personnel, healthcare services like midwives and community health volunteers, and also institutionalizing the delivery. So we wish to underscore that maternal death, we remain steadfast in our commitment to reduce the maternal mortality rate and endeavor it encompasses all aspects of the society, especially civil society. So I think we eagerly anticipate the discussion and insight that this event, which offers us the confidence that we will collectively have an effort and share knowledge, we can surmount the challenges we face today, and we build more resilient healthcare system in all of our country. Thank you so much. Thank you for having me.
So thank you so much. We have finished 1 minute ahead of time. So I think that was very good timekeeping. Thank you for everyone who have cooperated. Please join hands for the panelists as well as to each one of you, please. Thank you.